Well, thanks for joining me and joining this great conference today. I am Shamar Young. I hail from the University of Arizona, and we're going to talk about transarterial interventions for hepatocellular carcinoma. I'm going to go ahead and apologize in advance. I'm going to talk super fast because somebody who wastes much of their professional life thinking about these things, 8 minutes seems short, but we're going to get it done. If I can get my slides to go forward, hopefully. All right, here are my disclosures. So before we get started on the transarterial therapies, let's talk a little bit about HCC. So HCC is one of the few cancers you can actually diagnose by imaging alone. It often presents with cirrhosis, which is a really important factor to consider because it's often a competing factor for survival. And so basically, we can't just whack the liver and make it so dysfunctional that the patient can't continue surviving even though the cancer is dead. Transplantation is typically our ultimate goal. And this brings up things like the Milan criteria, which just defines how many cancers or how much cancer you can have to still get transplanted, bridging to transplantation, and downstaging. Those are just some concepts you're going to hear a lot about, so I wanted to introduce you to them. And also importantly, HCC receives a majority of its blood supply from the hepatic artery. That's different from the normal liver parenchyma, as I'm sure you remember from your first couple of years of med school. Most of the liver parenchyma gets its blood supply primarily from the portal vein, and that ends up being really important in our therapies, and we'll talk about that in a second. Here's just classic imaging appearance. Over here on the left, you see arterial enhancement, followed by early washout, and this ring around it we call a pseudocapsule. So this is a classic appearance of HCC. So when we talk about transarterial treatment options for HCC, we really have two large umbrellas. We have the transarterial embolization and chemoembolization umbrella, and then the radioembolization umbrella. We're going to talk about those separately, but because the steps have much in common, the two procedures have much in common in terms of steps, we're going to go ahead and just go through those together. So both of the procedures start by gaining access to the arterial system, either through the CFA or the radial artery. Here's just an ultrasound image of a needle entering an artery. And here's a angiogram through a sheath. So after you get the needle in, you put a wire through and then eventually put a sheath in. A sheath is just the tube that we work through. Next, we're going to access the celiac artery. Here's a celiac artery angiogram. This is your base catheter, splenic artery, and hepatic arteries over here. Followed by that, we're going to get more selective and go out into the common or proper. This is a run right from the junction of the common and proper hepatic artery, which of course transitions as the GDA comes off. This is the left hepatic artery, right hepatic artery, and GDA. Then we use typically a microcatheter to get even more selective. Here we are in the left hepatic artery with a microcatheter. And again, a microcatheter is just a smaller catheter that goes through your base catheter. And we continue to get more and more selective. One of the ways the field has advanced over the last few decades is more and more selective treatments. Here we are in a segment 2-3 branch and out here in the segment 3 branch. And as you can see, this is tumor thrombus. This is, tumor staining. This is all tumor here. So most people will also do a cone beam CT at some point, and this is often described as a poor man CT. This is a cone beam CT from this patient. As you can see, a lot of disease here. These are all HCCs, and so is this. This is from that left hepatic artery. What the cone beam CT really does for us is it helps to make sure that we have all the feeding arteries to the tumor, and we treat all of the tumor, not just treating 90% or 30%, et cetera, et cetera. Now, this is when the procedures start to differ quite a bit. So let's talk about transarterial embolization and chemoembolization first. So this is really based on the fact that the tumor does get the majority of its blood supply from the hepatic artery, which again is different than the normal liver parenchyma. So in transarterial embolization, our goal is just to induce ischemia by introducing small particles into the bloodstream that block up the blood supply to the tumor and cause the tumor tissue to die because of lack of blood supply. Now the difference between just transarterial embolization or TAE and TACE is that in TACE or transarterial chemoembolization, before we put those small particles in to stop up the blood supply, we give a high dose of chemotherapy right to the tumor. And it's really based on a two-hit hypothesis. Hey, we give you a bunch of chemotherapy, which is toxic to the tumor cells, and also we cut off your blood supply. So in TACE, there's two different forms. There's conventional TACE, and in this form, what we do is we mix chemotherapy with lapiodol. Lapiodol is a viscous substance that's radio-opaque, and we deliver that to the tumor, and then we give you the particles to cut off the blood supply. In DEB case, we combine those two steps in one. What we do is before the procedure, we load the chemotherapy onto the particles or the small beads that are going to stop up the blood supply, and then we introduce them into the bloodstream. They then slowly release the chemotherapy to the tumor over time. And here's just a case, patient that actually has 2 HCCs. On the top row, you see arterial enhancement, early venous washout, and this is just a T2 to show that gray matter. And this is a second HCC in the same patient, again, early washout, pseudocapsule, and T2. This is just a coronal view so that you can see that they do have 2. Here's an image from TACE. We're here in a blood supply, and you can see that we've given conventional TACE here. I know it's kind of hard to see, but this kind of weird grainy look, that's actually our Lepidol and chemotherapy. And this is just a still shot without subtraction, and you can see all this darkness in the tumor. That's not tumor blast, that's actually our C-TACE going in there. One thing after conventional TACE, when you use the Lepidol, is most people will end up getting a non-contrast enhanced CT to see how the Lepidol distributes. And what you want to see is like this one here over on your right screen, where there's nice Lepidol staining throughout the tumor. This over here on the left is actually not ideal. That is very worrisome that you did not actually find all the arteries and treat all the arteries, because this portion of the tumor does not seem to be covered by Lepidol at all. Here's our post-TACE MRI. Whenever we do liver work for cancer, we almost always want to follow with MRI because it's much better than CT in terms of contrast enhancement, which really allows us to make better decisions and find cancers earlier for a patient. And that looks great, but unfortunately this one here, a large portion of it is not dead. It's still viable. So what do? We went ahead and just ablated that. And this is what that looked like about a month later. So now we're going to move on to radioembolization. This is a form of brachytherapy where we induce small particles that have radiation attached to them and are incorporated within them into the blood supply that feeds the tumor. It is very different from TACE or TAE in that we don't actually want to stop up the blood supply at all. Radiation, as you guys know, induces free oxygen radicals, which cause double DNA strand breaks, and that's actually how it kills the tumor or the tissue. And so we want more oxygen, not less, and so we don't want to induce ischemia at all. We want to kill it with radiation. So we try not to reduce the blood supply. If anything, we like to increase the blood supply. I'm only really going to talk about yttrium-90. On one of my earlier slides, you saw under the radioembolization umbrella, there was holmium as well. Holmium is a radiotherapy or a brachytherapy that has been used in places in Europe, but we don't use it here in the US, so I'm just going to kind of ignore it. It's not available to us in the US, I should say. So the radioembolization treatment really consists of 2 procedures. The first is the mapping procedure, where again, we go through those steps I showed you at the very beginning. We select a number of arteries, do some cone beam CTs, continue to get more and more selective until we find the artery or the arteries which will be treated or which feed the tumor. We then give MAA, which is a test particle. And the natural question is, well, why are you giving MAA and not just the radiation? And there's really 3 reasons. First, the lung shunt fraction calculation. We need to make sure that not too much of the radiation is going to pass through the tumor and go to the lungs. This is really important because the vessels of the tumor are porous and they don't stop everything, and especially these small particles, like a normal capillary system would do. We need to see how it distributes within the perfused volume for our dose calculation. And then we need to ensure no radiation gets outside the liver within the abdomen. So to the bowel, to other parts of the abdomen, we really don't want that. Next, we do dosimetry, which is dose calculation. Really a very important step, in my opinion, the most important step of this whole procedure. And finally, we bring them back for the delivery. On the delivery day, we just select the artery or arteries we've already discovered feed the tumor procedure. and give them the special ordered dose of radiation that we calculated during the dosimetry step. So it's actually a fairly quick step there. So let's just go over a quick case of the radioembolization. This is a 64-year-old with Hep C-induced cirrhosis, found to have 2 HCCs. So one thing that we should look at here is this is an HCC up here, and then here's one here. This was pre-COVID actually when I treated this patient. He was traveling a lot. He didn't want to have both of them treated. He thought it would be too much, so we just did one at a time. This is an intra-arterial CT. So this is like a cone beam CT that I talked about earlier, except there is a diagnostic CT scan within the angio suite, and you can go ahead and just do a diagnostic CT, and it looks better, better resolution. And this is that dosimetry step that we talked about. So this is what it looks like. This is a dosimetry software where we're planning and understanding exactly how much dose is going to go to the tumor, how much dose is going to go to the normal tissue in the perfused volume. Perfused volume is just the total area of liver that you're going to treat. And we do our dose calculations, we deliver our tumor, and this is what they look like at 1 and then 3 months. One thing that's really important to understand about radioembolization, if you treat patients with TACE or TAE or ablation, you really expect to see a complete response at 1 month. That is what you expect to see. If you see any residual there, it's probably actually real live tumor. TARE is very different. Radioembolization is very different. It's very difficult to interpret anything at 1 month follow-up. 3 months is when we generally start making our treatment decisions. And typically speaking, this line here that you see by the arrow would be very concerning to me. But because we did our due diligence on dosimetry and did a post-procedural SPECT CT to take a look at it, we can see that we actually got 500 gray to the tumor itself. This made us feel good about being able to watch this patient, and this is what it looks like at 12 months. It completely shrunk down. I can tell you this patient actually went on to get a transplant, and there was complete pathologic necrosis of that tumor without any further treatment. So with that, I want to thank you very much for having me. This is my email. You should always feel free to reach out to me for any reason, especially if you want to nerd out about some of the topics we talked about today. That's one of my favorite things to do. And I'd be happy to answer any questions.